Imagine over 1.4 billion international tourist arrivals in a single year. I mean, that's nearly a 50% jump in less than a decade.
It's incredible, really. We're more connected than ever before.
Absolutely, and that's wonderful for so many reasons, right? New cultures, experiences, economic exchange.
Definitely huge benefits. But, all this constant rapid movement, it raises some big questions.
Like what it means for our health and the spread of diseases globally.
Exactly. It's not just interesting to think about, it's critical. It fundamentally reshapes public health as we know it.
How so?
Well, the sheer volume, and maybe more importantly, the speed of modern travel, it's created an entirely new landscape for how diseases behave. We really need a fresh look at how we protect ourselves and, global communities.
Okay, and that's exactly what we're here to do today. Welcome, everyone, to the Deep Dive.
Right. This is where we take a stack of information, your notes, articles, research, and really dig in.
We unearth the most important insights, maybe some surprising facts, and those aha moments that hopefully shortcut you to being truly well-informed.
And today, we're embarking on, I think, an incredibly timely and crucial deep dive. We're going to be exploring health recommendations for international travel.
And we're drawing heavily from some pretty comprehensive, authoritative medical sources here.
Yes, the goal is to equip you with the kind of knowledge and understanding that, frankly, elite professionals in this field would master, giving you a truly comprehensive perspective.
So we'll unpack the practical advice for travelers, right? But also explore the sort of medical nuances behind those recommendations.
And then we'll zoom out a bit, connect this personal journey, if you will, to maybe the biggest global health challenge of our time, climate change.
Ah, okay. And its impact on infectious diseases.
Precisely. Our aim is for you to get a real handle on how to navigate health in this hyper-connected and, rapidly changing world.
So what's the plan? Where do we start?
We'll kick off by looking at that dramatic increase in global travel we mentioned and what it immediately means for disease spread.
Okay.
Then we'll dive deep into the essential pre-travel health consultation. We'll break down crucial topics like immunisations, specific prevention strategies for things like malaria, traveler's diarrhea.
The usual suspects.
The usual suspects, yeah. And address other significant travel-related challenges too. Then we'll look at how these things shift for special populations.
Right, like pregnant travelers or immunocompromised individuals.
Exactly. And finally, we'll delve into how global climate shifts are fundamentally altering the landscape of infectious disease. And that'll link back to why understanding travel health is, more vital than ever.
Okay, sounds like a packed agenda. Let's unpack this. So starting with global mobility, you said the numbers are staggering.
They really are. It's not just a gradual increase, it's a fundamental shift. Between 2010 and 2018, international tourist arrivals, just tourists, shot up by an incredible 47.4%, reaching over 1.4 billion arrivals in 2018 alone. That's just a massive movement of people across borders.
And it's not just tourism driving this, is it?
Not at all. Think about the economic scale.
Yeah.
Total global merchandise exports hit a record $19.5 trillion USD in 2018.
Trillion.
That's nearly a threefold increase in just 2 decades. And that implies immense cross-border trade, which, inherently means countless people traveling for business, logistics, supply chains, all sorts of reasons supporting this global economy.
And geographically, where is this growth concentrated? Does that tell us anything?
It does. The highest growth rates for arrivals have been in Asia and the Pacific regions.
Okay.
This isn't just a dry statistic. It really points to a profound shift in global travel patterns. You're seeing new economic and cultural hubs emerging, playing a much bigger role on the world stage.
Now, obviously, we have to mention the elephant in the room, the COVID-19 pandemic. That threw a massive wrench in the works.
A huge disruption, absolutely. Travel plummeted in 2020, and the recovery in 2021 was, pretty limited.
But the expectation is that travel will bounce back.
The overwhelming consensus among experts is yes. The underlying drivers for global connection, for mobility, they remain incredibly strong. We fully anticipate things will eventually resume those pre-pandemic growth trends, which just reinforces why this topic remains so important long term.
So this huge rise in travel brings incredible benefits, social, economic, cultural connections. But you mentioned it's a double-edged sword when it comes to health.
Without a doubt. The benefits are clear, absolutely. But the sheer speed and volume of modern travel, it just fundamentally widens the range of infections any single person might encounter.
How so?
It's a direct consequence of increased exposure. You're moving through diverse environments, different geographic regions with different pathogens. It's a kind of biological globalization, if you like.
And the speed is key here. You contrasted it with 19th century travel.
Exactly. Think about it. Back then, crossing continents took weeks, maybe months, by ship. That time was often long enough for someone who got sick to either recover or, sadly, to die before they even reached their destination. The disease sort of ran its course during the journey.
But now
Now we can literally fly around the globe in less than 24 hours. And here's the critical, maybe slightly alarming point, that travel time is shorter than the incubation period for almost all common infections. Meaning a traveler can get infected, hop on a plane, and arrive at their destination before they show any symptoms. They're carrying the pathogen, potentially spreading it, but they feel perfectly fine. They become essentially silent, efficient vectors.
And we've seen the devastating results of that.
We have. Think about SARS back in 2003. It spread from Asia to multiple continents in just weeks.
I remember that.
Or the Ebola spread in 2014, and of course the profound global impact of the COVID-19 pandemic starting in 2020. These are pretty chilling examples of how modern air travel can facilitate rapid international spread of pathogens, often outpacing our ability to contain them.
And it's not just about new explosive epidemics, right? It can also reintroduce diseases.
That's another crucial point. This speed allows pathogens to be reintroduced into regions where they might have been controlled or even eliminated previously.
Yeah.
And once reintroduced into a vulnerable population, they can become endemic again.
Can you give an example?
A classic one is dengue fever. It was largely controlled in the Americas for a time, but starting in the 1970s, travel facilitated its reintroduction and spread throughout much of the region.
Okay.
And maybe a bit less directly tied to air travel speed, but still relevant to mobility, is the global spread of HIV infections back in the 1980s. It leveraged these same pathways of human connection and movement.
So the volume is up, the speed is incredible, diseases are spreading faster. What about who is traveling? Has that changed too?
Absolutely. That adds another layer of complexity. It's not just your traditional tourists or business folks anymore.
Who else are we seeing?
Well, while tourism and business trips are still huge, recent decades have seen growing numbers of students studying abroad, migrants moving for various reasons, people traveling specifically for medical procedures,
Right.
medical tourists, we call them.
Right.
And a really important group, often overlooked in terms of risk, is visiting friends and relatives, travelers, or VFRs.
Why are they often overlooked?
They tend to travel differently. Maybe stay longer, stay in local homes rather than hotels, eat more local food. Their exposure patterns can be quite different, and sometimes their pre-travel preparation is less formal. Each of these groups has distinct patterns, specific risks, and maybe different levels of health prep.
And it's not just the type of traveler, but also their underlying health. More vulnerable people are traveling now.
That's a key trend. We're seeing more and more individuals with pre-existing conditions or vulnerabilities traveling internationally. This includes elderly people, infants, pregnant women, and those with chronic medical issues, especially people whose immune systems might be weakened, maybe due to illness or medication.
Which means the responsibility for travel health advice isn't just for specialists.
Exactly. This really broadens the scope. Whether you're a dedicated travel doctor, a primary care provider, maybe even working in urgent care or a hospital, you will encounter patients who have traveled internationally. Understanding these travel health nuances isn't niche knowledge anymore. It's really becoming an essential part of comprehensive, modern patient care for almost any clinician.
Okay, so with all this complexity, more people, faster travel, diverse travelers, including vulnerable ones, what kind of health problems are travelers actually experiencing? What does the data show?
It might genuinely surprise you how common it is to get sick when traveling. Studies consistently show that somewhere between 43% and maybe up to 79% of travelers report developing some kind of illness, either during their trip or shortly after returning.
Wow, that's a huge range, but even the lower end is almost half.
It is. Now, thankfully, most of these illnesses are minor. Traveler's diarrhea is by far the most common complaint. But a small yet significant percentage, typically around 1% to 3%, do end up needing hospitalization. And that can obviously be a major disruption, not to mention expensive.
And focusing on infections we can vaccinate against, what's the biggest culprit for travelers?
For travelers heading to lower-income countries, influenza the flu is actually the most commonly reported vaccine-preventable infection picked up during travel.
More common than things like typhoid or hepatitis A.
Yes, significantly more common than flu. Though typhoid and Hep A are still diagnosed more frequently among travelers than some of the, let's say, more exotic diseases we sometimes associate with travel medicine like cholera, Japanese encephalitis, or yellow fever, but those are still definitely important to consider depending on the destination.
And specific outbreaks can suddenly change those relative risks, right?
Precisely. Things can shift dramatically. For example, there was a large yellow fever outbreak in coastal southeastern Brazil back in 2017-2018.
I remember hearing about that affecting areas not usually considered high risk.
Exactly. Or think about the cholera outbreak linked to the Haiti earthquake in 2010. Both events led to significant jumps in travel-associated cases of those specific diseases. It really highlights how dynamic global health risks are and how quickly a localized problem can impact international travelers.
But we need to look beyond just infections you mentioned. What else poses significant risks?
Indeed, this is a really crucial point that often gets missed in the focus on scary tropical diseases. Injuries are actually a much more common cause of death for international travelers than infections.
Really? More common than malaria or typhoid fatalities?
Yes.
Yeah.
For instance, looking at data for U.S. citizens traveling internationally between 2015 and 2016, the leading causes of death were things like motor vehicle accidents, homicide, suicide, and drowning. These significantly outnumbered deaths from infectious diseases.
That's sobering.
It is. And beyond physical injury, we also need to acknowledge the psychological impact. The stresses of travel, being in an unfamiliar environment, dealing with logistics, maybe language barriers can sometimes exacerbate or even uncover underlying psychiatric disorders. Depression and anxiety are actually pretty common reasons for needing medical evacuation from overseas.
Okay, so we've got this complex picture. Massive travel volume, incredible speed, diverse travelers, infectious risks, non-infectious risks like injuries and mental health. What does this all mean for actually preparing to travel? Or for advising people who are?
Well, it all points to the absolute necessity of the pre-travel consultation. That's really the cornerstone of safe international travel.
Right. Think of it as your essential roadmap, kind of systematically preparing you for the unique health landscape of wherever you're going.
Exactly. And whether you're seeing a specialist travel clinic or just your regular primary care doctor, there are 5 key elements that really must be covered in that consultation. It's not just ticking boxes. It's a framework for being truly prepared.
Okay, what's the first element?
First is a thorough trip risk assessment. This means digging into both the nitty-gritty details of your itinerary and your personal health profile.
So, itinerary. More than just the country name.
Oh, much more. We need specifics. Which regions within the country? When are you going? Rainy season, dry season? How long? How are you traveling? Plane, bus, boat? What kind of accommodation? Fancy hotel or local guest house? Even the reason for travel matters. Tourism, mission work, visiting family, maybe adventure stuff like trekking at high altitude.
Okay, that makes sense. And the other side of that assessment?
Is the traveler profile.
Yeah.
This gets into your medical history, any current medications you're taking, known allergies, drugs, food, environmental stuff, your pregnancy status or plans, and even your general tolerance for risk.
And the provider's role here is
to help you identify all those potential risks so you can make a genuinely informed decision. Sometimes that might even involve advising against travel. Maybe if there's a really dangerous outbreak, or if you medically can't take critical prevention, like malaria pills. It should be a shared decision-making process, really empowering you with the knowledge.
Got it. So, risk assessment first. What's element number 2?
Immunisations. This is about getting personalized recommendations. What vaccines are required by the country for entry, and what others are generally recommended based on your specific trip and your vaccination history.
And understanding any precautions or reasons why maybe a vaccine isn't right for you.
Precisely. And a key part of this is the official paperwork. For required vaccines, like yellow fever, you need that International Certificate of Vaccination Prophylaxis, the yellow card.
Why is that so important?
Because without it, you can face serious problems on arrival. Denied entry, forced vaccination at the border, maybe even quarantine. It's taken very seriously.
Okay. Third element.
Malaria and arthropod-borne infection prevention. This is huge. It means carefully assessing the malaria risk where you're going, considering your accommodation, your activities, and knowing about any local drug resistance patterns.
Which then leads to
Prescription of preventive medication, chemoprophylaxis when it's needed, but it's also about practical advice.
Yeah.
How to avoid mosquito bites, tick bites, that sort of thing. And importantly, knowing how to recognize early symptoms, especially of malaria.
Oh.
Yeah. Again, all tailored to your health, considering other meds you take for potential interactions.
Makes sense. Fourth.
Gastrointestinal illness prevention, basically avoiding travelers' diarrhea and other stomach bugs. This involves talking about hygiene standards, water quality at your destination, and thinking about where your food's coming from. Restaurants, street food, home cooking.
And this advice needs tailoring too, right? Not everyone travels the same way.
Absolutely. It needs to fit your travel style, your eating habits, and you need to consider potential drug interactions if you're carrying antibiotics for self-treatment. It's about practical, actionable steps to keep your gut happy.
Okay, and the fifth key area, you said it covers a lot of ground.
It does. It's sort of the catch-all for other important topics. Things like preventing waterborne infections besides diarrhea, like schistosomiasis, how to avoid injuries and crime, protecting yourself from animal bites and rabies, understanding risks of STIs, managing altitude sickness, preventing blood clots on long journeys,
Wow.
coping with jet lag, motion sickness, managing severe allergies, understanding travel health and medical evacuation insurance, what to put in your health kit, how to travel safely with medications, even tips for mental well-being and cultural adaptation. It's a truly holistic view of travel health.
You really emphasize the detailed itinerary being critical. Why is that level of detail so necessary?
Because general advice isn't enough. Knowing the specific cities, the exact rural areas, the types of activities, are you hiking in forests or staying in urban centers,
Yeah.
the kind of accommodation, all that determines your specific risks and the precise preventive measures needed. Well, the duration of your trip matters for things like malaria prophylaxis. The sequence of countries you visit, even transit stops, can trigger immunization requirements, especially for yellow fever or polio. Without the details, the advice can be way off.
So how do doctors stay current? This information changes all the time, disease outbreaks, new vaccine advice.
It's a constant challenge. Reliable resources are absolutely essential. There are excellent authoritative online sources that provide up-to-date, country-specific recommendations.
Like what?
The U.S. Centers for Disease Control and Prevention, the CDC, has a fantastic traveler's health website, cdc.gov travel. That's a primary go-to. There's also the CDC Yellow Book, which is like the Bible of travel medicine.
Okay.
The U.S. State Department offers travel advisories focusing on safety and security. The World Health Organization, WHO, provides global perspectives. And there are even specialized sites for specific things like managing jet lag or travel with severe allergies. The key thing is providers must routinely check these resources because recommendations and entry rules can change unexpectedly, sometimes overnight.
And beyond the itinerary, the traveler's personal medical profile is just as crucial for tailoring that advice.
Indisputably. Key things to review are age, your full medical history, your vaccination records, all current medications, prescription and over-the-counter, any allergies, drug, food, environmental, and pregnancy status or plans.
Are there common health issues that need special attention?
Definitely. Conditions that weaken the immune system like HIV or being on immunosuppressive therapies need careful consideration. Same for significant heart or lung conditions, or serious liver or kidney problems, which can affect which malaria prevention drugs are safe to use. This detailed medical review is what makes the advice truly personalized and, most importantly, safe.
Now, who's best placed to give this advice? Should everyone try to find a specialized travel clinic?
Specialized travel clinics are great. They often have doctors certified in travel health, deep expertise, and access to all the specialized vaccines.
Yes.
However,
Yes.
many travelers just don't go to them. Often they don't realize the risks or they aren't even aware these clinics exist.
So primary care providers have a big role to play.
A huge role. We strongly encourage primary care docs to tackle travel health during routine visits. They know their patients' histories best, which is a big advantage.
But when should a primary care provider refer someone to a specialist?
Referrals make sense if the traveler needs vaccines not usually stocked in a general practice, like yellow fever. Or if the itinerary is really complex, maybe multiple countries with different risks. Or if the traveler has a complicated medical history. Or, frankly, if the primary care doc just isn't familiar with the latest recommendations for a specific destination or preventive drug regimen. The specialist can provide that highly nuanced guidance.
And timing is key, you mentioned, especially for vaccines. How far ahead should people plan?
Ideally, that pre-travel consultation should happen at least 4 to 6 weeks before departure.
Why so early?
It allows enough time for vaccine series to be completed. Some vaccines require multiple doses spaced weeks apart to build full immunity before you leave.
But what if someone's traveling last minute? Is it too late?
No, definitely not too late. Even if you can't make that ideal 4-6 week window, a consultation closer to the travel date is still incredibly beneficial. You might need accelerated vaccine schedules or just get crucial last-minute advice on prevention. Any preparation is always better than none.
Let's talk about cost, because that's often a real barrier. Travel vaccines, malaria pills, they can be expensive, and insurance often doesn't cover them.
That's a very real challenge, absolutely. Providers have a crucial role here in helping travelers on a limited budget prioritize. Based on the specific risks of the trip and the traveler's health, we can help them understand which preventative measures offer the biggest bang for the buck, so to speak.
So, focusing on the highest impact interventions first.
Exactly. So that decisions about maybe skipping a lower risk recommendation aren't just based on cost, but on an informed understanding of the relative risks, ensuring the most critical measures are still strongly considered, even if others have to be skipped.
Okay, let's zoom in on immunizations now. There's such a critical piece of this. You mentioned the categories have evolved.
Yeah, historically, we talked about routine, recommended, or required vaccines for travel, but it's blurrier now.
How so?
Well, many vaccines that used to be mainly for travel, like hepatitis A, are now part of routine childhood or adult schedules in places like the U.S. So a vaccine can be both routine and recommended for travel. The categories aren't rigidly separate anymore. The key is figuring out what you, as an individual traveler, need based on where you're going in your history.
And for those vaccines that are legally required for entry, the yellow card is essential.
That's the International Certificate of Vaccination Prophylaxis, or ICVP. It's the official proof. Without it for required vaccines, you can face those serious consequences we talked about. Denied entry, vaccination on arrival, quarantine, penalties.
Yellow fever being the classic example requiring it for entry from endemic to non-endemic countries.
Exactly. And while medical waivers exist for specific situations where someone can't be vaccinated, it's vital to remember that a waiver doesn't magically remove the health risk of traveling unvaccinated. It just addresses the entry requirement.
Now, if someone needs multiple vaccines, can they get them all at once in that pre-travel visit?
Generally, yes. Most common travel vaccines can be given on the same day, in different injection sites, of course.
Are there exceptions?
A few specific ones, like oral typhoid vaccine should be given at least 8 hours after the oral cholera vaccine. But the more important rule involves live virus vaccines.
Which ones are those again?
Yellow fever, MMR, that's measles, mumps, rubella, the live attenuated flu vaccine nasal spray, and varicella, the chickenpox vaccine.
Okay, so what's the rule for those?
The recommendation is to give them either all on the same day or separated by at least 28 days.
Why the separation?
Because giving live vaccines too close together but not on the same day could potentially interfere with the immune response to the second vaccine, making it less effective. If you absolutely can't stick to that schedule, the advice is usually to repeat the second vaccine after at least 28 days to be sure immunity develops properly.
Okay, let's run through some key immunizations. Hepatitis A, you said it's pretty common for travelers.
Very common. It's spread through contaminated food and water, usually due to poor hygiene. Risk is highest in countries with inadequate sanitation. Think South Asia, Sub-Saharan Africa.
And the vaccine.
For younger, healthy adults, a single dose usually provides protection before travel. A booster shot 6 to 18 months later gives lifelong immunity. For some groups, older adults, people with weak immune systems or chronic liver disease, we might consider giving immune globulin, which is a shot of antibodies, along with the first vaccine dose for immediate, short-term protection while the vaccine kicks in.
What about hepatitis B? How is that usually transmitted to travelers?
Hep B is spread through infected blood or body fluids. While it can happen through unsafe medical procedures, travelers are strongly warned against high-risk activities like getting tattoos or piercings in unregulated places or having unprotected sex.
Who needs the vaccine most?
Well, it's good for all travelers. It's especially important for long-term travelers, healthcare workers going on missions, and anyone who might have sexual encounters abroad. If you're not already immune, there are accelerated vaccine schedules available, including combined Hep A, Hep B shots to get you protected faster.
Influenza the flu. You said it's super common even outside the typical flu season at home.
Absolutely. Because flu seasons vary around the world and it circulates year-round in the tropics, vaccination is important regardless of the season back home. Getting the flu, even a mild case, can completely wreck your travel plans, and you risk bringing it back to vulnerable people at home.
Measles, mumps, rubella, MMR measles seems to be making a comeback globally.
Sadly, yes. WHO reported a huge surge in global measles cases in 2019, even in high-income countries. And despite the U.S. eliminating endemic measles transmission years ago, we've seen outbreaks sparked by infected travelers, often unvaccinated or undervaccinated individuals.
Fueled by vaccine hesitancy.
Significantly contributed by it, yes. Measles is incredibly contagious, and transmission can even happen in airports or on planes. So ensuring adults have proof of 2 MMR doses or other evidence of immunity is really crucial before international travel.
Okay. Tetanus, diphtheria, pertussis, Tdap, just making sure you're up to date.
Pretty much. Standard boosters are important. Diphtheria is still around in places with low vaccination rates. For tetanus, the standard booster is every 10 years, but some experts suggest getting one earlier if you're doing high-risk activities in a remote area with limited medical care, just because injuries are more likely and treatment might be delayed.
Typhoid fever, where's the risk highest for that?
It's caused by Salmonella typhi bacteria, spread through contaminated food and water. Most cases in travelers from high-income countries are acquired in South Asia. Africa and Southeast Asia are also high-risk areas.
Is it as common as traveler's diarrhea?
Generally less common than TD or Hep A, but what's worrying is the rise in antibiotic resistance, especially in South Asia. That makes prevention even more important. There are 2 vaccines, an injection and an oral live vaccine in capsules. Important note, the oral one isn't usually for immunocompromised folks, and neither vaccine protects against a related illness called paratyphoid fever.
And varicella chickenpox.
Still very common, endemic in many low and middle income countries. So if you haven't had chickenpox or the vaccine, making sure you have immunity, usually via 2 doses of the vaccine, is important before travel.
All right, now for vaccines more specific to regions or situations, yellow fever, the one with the strict international rules.
That's the one. It's a serious viral disease found in parts of sub-Saharan Africa and South America. Entry requirements are complex and vary wildly. Some endemic countries require proof for everyone arriving internationally. Many non-endemic countries require it only if you're arriving from an endemic country, or even just had a long transit stop there recently.
And you need the official yellow card.
Yes, the ICVP. The vaccine itself is only given in state-authorized clinics, and they record it on that card.
And the validity is really lifelong now.
For entry purposes, yes. A single dose is considered valid for life, starting 10 days after you get it. WHO changed the rule back in 2016, removing the old 10-year booster requirement for entry.
But boosters might still be recommended for some people.
They are, in specific situations. After 10 years, a booster is recommended for certain individuals whose initial immune response might have been weaker or waned, like women pregnant when they got their first shot, people with HIV at the time, or bone marrow transplant recipients if their immune system recovered. Also, for travelers facing particularly high ongoing risk, like during an active epidemic or for very long stays in highly endemic areas.
It's a live vaccine, so there are safety considerations, right? Contraindications.
Yes, absolutely. Being a live attenuated vaccine, it's generally not given to people with severely weakened immune systems, certain cancers, advanced HIV, conditions affecting the thymus gland. Severe egg allergies are also a contraindication. There are also precautions for adults 60 and older, pregnant or breastfeeding women, and those with milder HIV. If travel is unavoidable for someone in these groups, a medical waiver can be issued, but they still need to understand the risks of going unvaccinated.
And what about side effects? I know serious ones are rare, but they exist.
Most reactions are mild, low fever, aches, soreness at the injection site. But rare, serious adverse events can happen. These include severe allergic reactions, anaphylaxis, neurological problems like brain inflammation or Guillain-Barré syndrome, and the most concerning one, yellow fever vaccine-associated viscerotropic disease, or YEL-AVD.
What is YEL-AVD?
It's a severe illness that mimics actual yellow fever, affecting multiple organs, and it can be fatal. The risk is very low, roughly 0.3 cases per 100,000 doses administered. But the risk is known to be higher in people over 60, and those with certain immune issues. So, while it's rare, the potential severity means a very careful risk-benefit discussion with your doctor is essential before getting the vaccine.
Poliomyelitis polio. Mostly eradicated, but still a concern.
Yes, while wild-type polio is nearly gone, we now worry about circulating vaccine-derived poliovirus, CVDPV. This could emerge and spread in areas with low immunization rates.
So what's the travel recommendation?
For adults who completed their childhood polio series and are traveling to countries reporting any poliovirus transmission, wild or vaccine-derived, within the last year, a single lifetime booster dose of the inactivated polio vaccine, IPV, is recommended. This might also apply to travel to bordering countries. And critically, some high-risk countries may require proof of recent vaccination before you leave to prevent you from exporting the virus. The list of countries changes, so checking current WHO or CDC guidance is vital.
Cholera. Where's the risk for travelers?
Endemic, mostly in Africa and Asia, plus Haiti since the earthquake. It's mainly spread through contaminated water, but food and person-to-person spread happen too. For most tourists sticking to good hygiene, the risk is extremely low.
So, who might consider the vaccine?
Maybe those going to active outbreak zones, healthcare workers on missions, people who know they'll struggle with strict food-water hygiene, or those at higher risk for severe disease if they did get infected, perhaps due to underlying conditions or very remote travel with no healthcare access. There's a single-dose live oral vaccine available in the U.S.
Meningococcal disease, bacterial meningitis.
Can happen worldwide, but the big focus for travelers is the African meningitis belt during the dry season, roughly December-June, when huge epidemics can occur.
Which vaccine is recommended?
The quadrivalent vaccine, protecting against serogroups A, C, Y, and W135. Conjugate vaccines are generally preferred over polysaccharide ones. And remember, proof of this vaccination is required for pilgrims traveling to Saudi Arabia for Hajj and Umrah.
Japanese encephalitis, the mosquito-borne one in Asia.
Yes, viral infection spread by evening-biting mosquitoes in much of Asia and parts of the Western Pacific. Overall risk for short-term travelers is very low, less than 1 case per million.
But higher risk for some.
Yes, risk increases for long-term expats, those in rural areas during peak season, or people with lots of outdoor exposure in the evenings. Vaccination is an option for those at higher risk. There's an inactivated vaccine called XIRO available in the US and Europe, usually a 2-dose series.
Rabies. Always a scary thought.
Found on all continents except Antarctica. Main reservoirs are wild carnivores and bats, but in many countries with poor animal control, dog bites are the most common way humans get infected.
So prevention is key.
Absolutely. Rule number 1 is avoid contact with animals, wild, stray, even unfamiliar pets, and know what to do immediately if bitten or scratched. Thorough wound washing and urgent medical evaluation for post-exposure shots.
What about pre-exposure vaccination?
The 3-dose pre-exposure series is considered for higher risk travelers, maybe field biologists, cavers, people going to very remote areas where getting the post-exposure treatment, especially the immune globulin part, might be difficult or delayed. But, and this is crucial, even if you've had the pre-exposure shots, you still need urgent booster doses of vaccine after a potential exposure. It just simplifies the post-exposure treatment and gives you a head start.
Lastly, tick-borne encephalitis, TBE.
Viral infection, endemic in parts of Europe and Asia, spread mainly by infected Ixodes ticks, but also potentially through unpasteurized milk from infected animals.
Prevention.
Personal protection against tick bites is key if you're hiking or camping in endemic forests. Cover up, use repellents, check for ticks daily. Importantly, while TBE vaccines are available in those endemic areas, they're not available in North America, so prevention relies on bite avoidance.
Okay, that covers the vaccine landscape pretty thoroughly. But, as you said, many threats don't have a vaccine. What about battling those bugs and bacteria, like malaria or the dreaded traveler's diarrhea?
Right, moving beyond vaccines, tackling things like malaria, requires a really robust, multi-pronged strategy. It's still a leading cause of life-threatening infections in travelers.
And it's caused by Plasmodium parasites.
Correct. Several species, but Plasmodium falciparum is the most dangerous, the one most likely to kill. Sub-Saharan Africa carries the vast majority of the global malaria burden.
And cases in travelers returning to places like the U.S. are often preventable.
Sadly, yes. Most cases reported in high-income countries are acquired during travel, and often it's because people either didn't take their preventive medication or didn't take it correctly. And interestingly, as we mentioned, VFR travelers visiting friends and relatives are a common group affected. They might wrongly assume they still have immunity from childhood, or perhaps perceive their risk as lower.
So what are the core prevention strategies? You mentioned 3.
Yes, 3 equally vital parts. First is mosquito avoidance. The Anopheles mosquitoes that spread malaria are primarily active from dusk until dawn.
So practical steps.
Limit outdoor activities during those evening and nighttime hours. Stay in well-screened or air-conditioned places. Wear long sleeves and long pants. Use insect repellent liberally on exposed skin day to eat. At 20-50% concentration is generally preferred by experts. Treating clothes with permethrin adds another layer of protection. And if your sleeping area isn't securely screened, Sleeping under an insecticide-treated bed net is crucial.
What about things like insecticide sprays for the room?
Their effectiveness in actually preventing malaria transmission isn't definitively proven, and there can be risks from inhaling the spray, so the focus is really on personal protection and bed nets.
Okay, avoidance first. Second strategy.
Chemoprophylaxis. That means taking preventive medication. This is strongly recommended for travelers going to higher risk malaria zones.
What drugs are used?
There are several effective options. Atovaquone, proguanil, Malarone is a common brand name. Doxycycline, mefloquine are common ones. Primaquine and tefenoquine are others, sometimes used for specific types of malaria or after travel.
How does the doctor choose which one?
It depends heavily on your specific itinerary. Exactly where you're going determines the type of malaria and, critically, any local drug resistance patterns. Your personal medical history, other medications you take, potential side effects, and contraindications are all factored in. It's a very personalized decision made with your healthcare provider.
Some travelers worry about side effects from these drugs, sometimes quite serious ones mentioned online. Are those concerns valid?
That's a really common question, and it's important to address it directly. Look, all medications can have side effects, but the currently approved malaria prevention regimens are generally well tolerated by most people. Fears about severe side effects like serious liver damage with Malarone or psychosis with mefloquine, while possible in rare cases, are often exaggerated or not broadly supported by large-scale clinical evidence for the majority of travelers.
So the benefit usually outweighs the risk.
Overwhelmingly, yes. Healthcare providers need to emphasize that malaria can be fatal and chemoprophylaxis can be life-saving. When it's indicated, the benefits of preventing a potentially deadly disease far outweigh the very low risk of serious side effects for most people.
Got it. And the third strategy.
Early recognition and prompt treatment if infection occurs despite prevention. This is absolutely critical because once malaria symptoms start, the disease, especially falciparum malaria, can progress to severe illness incredibly rapidly, sometimes within just hours.
So any fever after being in a malaria zone is a potential emergency.
Absolutely. Any traveler who develops a fever during or after visiting a malarious area needs to seek medical evaluation immediately. Don't wait. Some people traveling to extremely remote areas might carry a standby or emergency self-treatment course of malaria medication, but this is only for situations where medical care is completely inaccessible and should only be used under prior medical advice. It is never a substitute for taking regular preventive medication. The CDC, for instance, generally doesn't recommend it as an alternative strategy.
Okay, so that's malaria. But there are lots of other diseases spread by insects or ticks, arthropod-borne infections, and many lack vaccines or specific preventive drugs.
That's right. Dengue fever, for example, is the most common arbovirus that's a virus transmitted by arthropods worldwide. It's the leading cause of fever in travelers returning from most tropical and subtropical areas, except for sub-Saharan Africa, where malaria usually dominates that statistic.
And the risk for these isn't static, right? It can change.
Very much so. Risk varies by year, by season. Rainy versus dry often matters. And risk can increase dramatically during active outbreaks. We saw this clearly with the large chikungunya and Zika virus epidemics in recent years.
And it's not just mosquitoes we need to worry about.
Correct. While Aedes mosquitoes are notorious vectors for dengue, chikungunya, Zika, and others, different diseases are spread by non-Aedes mosquitoes. Ticks transmit things like Lyme disease, tick-borne encephalitis, and various rickettsial infections. Sandflies transmit leishmaniasis, tsetse flies transmit African sleeping sickness, triatomine bugs transmit Chagas disease. It's a diverse group of vectors and diseases.
And since vaccines are limited here, what's the main defense?
You hit it. Immunizations are only available for yellow fever, Japanese encephalitis, and tick-borne encephalitis, and TBE vaccine isn't available in North America. So for the vast majority of these other arthropod-borne diseases, prevention relies almost entirely on avoiding bites from insects and ticks.
So similar advice to malaria prevention.
Generally, yes, repellents, protective clothing. But a key difference is that many of these other vectors, unlike the malaria mosquito, bite during the daytime. And they can be found in a wider variety of environments, so vigilance is needed throughout the day. Specific advice also includes things like tucking pants into socks in tick areas and doing daily tick checks, or avoiding sleeping in traditional mud or thatch housing in areas where Chagas disease bugs might live.
Okay, let's switch gears to that other common travel ailment, traveler's diarrhea, or TD. You said it affects a huge percentage of travelers.
It really does. Estimates range from 30% up to 70% of travelers, depending on the destination and length of stay. Symptoms typically include sudden onset of loose stools, often with abdominal cramps, maybe fever or vomiting. Severe cases can lead to significant dehydration or involve bloody diarrhea, which we call dysentery.
What causes it usually?
About 80% of the time, it's bacterial.
Uh-huh.
Common culprits are specific types of E. coli, Campylobacter, Shigella, and Salmonella. A smaller percentage of cases are caused by viruses, or sometimes parasites like Giardia. It's most common in low and middle income countries where food and water hygiene standards might be lower.
So prevention is clearly the best strategy if possible. What are the key precautions?
It really boils down to careful food and beverage choices, plus meticulous hand hygiene. The old adage for food is cook it, boil it, peel it, or forget it.
Meaning,
Food is safest when it's cooked thoroughly and served piping hot. Uncooked fruits and vegetables are risky unless you can wash and peel them yourself. Dairy should be pasteurized.
and water.
Stick to commercially bottled water, making sure the seal is intact. Refilling bottles is unfortunately common in some places. Or use chemically purified water. Avoid ice cubes, as often made from local tap water. Be cautious with beverages from street vendors. If you're in a remote area without safe bottled water, you need reliable purification methods. Boiling is best, but chemical treatments, filters, or UV devices can also work. And underpinning all of this, wash your hands frequently and thoroughly, especially before eating.
What about taking something before you travel to prevent TD? Are there options?
Options for actual prophylaxis are limited. Bismuth subsalicylate, the active ingredient in Pepto-Bismol, can reduce the incidence of TD by about 50%, but only for short-term use, say less than 3 weeks.
Why only short term? And are there downsides?
Well, the dosing is pretty inconvenient, often 2 tablets or a dose of liquid 4 times a day. And side effects like constipation and a harmless but weird black tongue are common. Plus, it can interact with other medications. So it's not practical for many travelers. Probiotics have been studied, but the evidence they consistently prevent TD isn't strong yet, though research continues.
What about taking antibiotics preventively? That sounds like it would work, but I sense hesitation.
Strong hesitation. Using antibiotics for routine TD prevention is generally not recommended.
Why not?
There are major concerns, potential side effects from the antibiotics themselves, the risk of promoting antibiotic resistance in your own gut bacteria, and the serious risk of wiping out your good gut bacteria, which can lead to nasty infections like C. difficile colitis. It might also make you more susceptible to colonization with multi-drug resistant organisms, MDROs.
So only in very specific cases.
Exactly. Short-term antibiotic prophylaxis is considered only in rare situations for travelers at exceptionally high risk of complications if they were to get TD. Maybe someone with severe underlying inflammatory bowel disease or significant immune compromise. For most people, the risks outweigh the benefits. And that oral cholera vaccine we mentioned, it offers only minimal cross-protection against one type of E. coli, so it's not a broad TD prevention tool.
Okay, so prevention is key, but often fails. If you do get TD, what's the self-treatment strategy?
First, remember most TD is self-limited. Bacterial cases usually clear up in 3 to 7 days. Viral is shorter. Parasitic, it might last longer. Self-treatment should be guided by how sick you feel, how much it's impacting your activities.
How do you classify that?
We usually think of it as mild. You feel unwell but can still do things. Moderate, it's distressing and interferes with your plans. Or severe, you're basically incapacitated. And importantly, any diarrhea with blood or mucus in it is automatically considered severe.
What's the absolute first step in treatment, regardless of severity?
Fluid and electrolyte replacement. That's crucial to prevent dehydration. For severe cases, oral rehydration solution, ORS packets, mixed with safe water are ideal. You can buy these over the counter. For milder cases, just drinking any safe fluids you can tolerate, bottled water, broth, diluted juice is important.
What about medications for symptoms?
For mild or moderate TD, an antimotility agent like loperamide, Imodium is a common brand, can be used alone to reduce the frequency and urgency of bowel movements.
And antibiotics for treatment? We talked about the risks for prevention. What about using them once you're already sick?
Using antibiotics for treatment can definitely shorten the duration of TD, often down to just a day or two. Using loperamide alongside the antibiotic might provide even faster symptom relief. However,
Because we're still there.
yes, the risks we discussed still apply. Side effects, drug interactions, and especially the negative impact on your gut microbiome. That disruption can increase your risk of C. difficile later and make you more likely to pick up and carry those multi-drug resistant organisms, MDROs. Carrying MDROs can then put you at higher risk for hard-to-treat infections, like UTIs, even months after your trip. The role travelers play in spreading MDROs globally is a huge public health concern.
So, given those risks, when are antibiotics recommended for self-treatment?
The current recommendation is that routine self-treatment with antibiotics should be reserved only for severe TD.
Okay, and if you have severe TD, which antibiotic is preferred?
Azithromycin is generally the first choice, especially for severe diarrhea, or if you're traveling in areas with high rates of resistance to older antibiotics like fluoroquinolones, particularly Southeast Asia and South Asia, where Campylobacter resistance is common. The usual dose is 500 milligrams once daily for 3 days, or sometimes a single 1,000 milligram dose. Other options like rifaximin might be considered, but azithromycin is usually preferred for severe or dysenteric illness. Critically, you should not just empirically take anti-parasitic drugs like metronidazole for acute TD unless a specific parasitic infection has been diagnosed.
What if symptoms drag on for weeks after returning?
If diarrhea or other gut symptoms persist for 14 days or longer, that's considered protracted diarrhea. It needs proper medical evaluation. It could be due to a persistent infection, often parasitic, a secondary infection like C. difficile that developed after antibiotic use, or sometimes it triggers post-infectious irritable bowel syndrome, IBS. Interestingly, using antibiotics for the initial TD hasn't been shown to prevent post-infectious IBS, so long-lasting symptoms definitely warrant a doctor visit and specific testing.
Okay, we've navigated the infectious disease landscape pretty thoroughly. But travel health isn't just about bugs. What about other challenges, especially those tied to specific activities or for specific groups of travelers?
Absolutely. There are definite activity-specific risks. Take freshwater exposure, for example.
Swimming in lakes or rivers.
Exactly. Travelers should really avoid direct skin contact with freshwater bodies in many parts of the world due to the risk of infections like leptospirosis and schistosomiasis. Schistosomiasis is a nasty parasitic infection found in Africa, Asia, and South America. Popular tourist activities like diving in Lake Malawi or rafting the Nile put people at risk. Knowing where these risks exist is key.
And something as simple as footwear matters.
Hugely important. Wearing appropriate closed-toe shoes in tropical countries isn't just about comfort. It protects against soil-transmitted parasites like hookworm, which can burrow through bare skin. Plus, it reduces the risk of cuts, injuries, and even snake bites. And generally, avoiding contact with animals, wild, stray, even unknown pets, is always wise to minimize bite and scratch risks and potential diseases like rabies.
We also need to touch on sexual and bloodborne risks during travel.
Yes, it's an important consideration. Travelers engaging in casual sex abroad, particularly without using condoms, face a significantly higher risk of STIs. Similarly, activities like getting tattoos, piercings, or even acupuncture in places with questionable hygiene standards carry a risk of bloodborne infections like HIV, hepatitis B, and hepatitis C. Awareness and avoiding these high-risk behaviors are critical.
Okay, shifting to non-infectious issues. What about blood clots, VTE, on long journeys?
Venous thromboembolism, deep vein thrombosis, or pulmonary embolism is a recognized risk, especially after long flights or any prolonged immobility.
Prevent?
Simple things help. Get up and walk around when possible. Do calf exercises in your seat. Try to get an aisle seat for easier movement.
Sure.
For people at higher risk, maybe a history of clots, certain medical conditions, graduated compression stockings can be beneficial. In very high-risk cases, a doctor might even prescribe preventive blood thinners for the travel period.
Altitude illness, a big one for mountain destinations.
Yes, for travel above about 2,500 meters or 8,000 feet. Travelers need counseling on the risks, how to recognize symptoms which can range from mild headache to life-threatening brain or lung swelling, and strategies for acclimatization, like ascending gradually. Prophylactic medication, often acetazolamide, might be prescribed. Think destinations like Cusco in Peru, Kilimanjaro, trekking in Nepal.
And jet lag, the bane of long-haul travelers.
It really disrupts things. It occurs when your internal body clock gets out of sync with the local time after crossing multiple time zones, usually 3 or more. Symptoms are fatigue, poor sleep, daytime drowsiness, GI upset, mood changes.
Any effective strategies?
Shifting your sleep schedule gradually before you leave can help. After arrival, timed exposure to bright light is key. Melatonin supplements, taken at the right time, can also aid adjustment. There are online tools and apps that try to help plan this, though their clinical proof varies. Be cautious with caffeine. It helps alertness, but can mess up sleep later. And sleeping pills on flights need careful consideration, especially ensuring you have enough time for a full sleep, and being aware that some are restricted in certain countries.
You mentioned earlier that injuries are a major cause of death for travelers, even more than infections. Why is the risk higher when traveling?
It's a combination of factors. Unfamiliar environments, maybe language barriers making it hard to understand warnings or get help, reliance on others, like tour operators whose safety standards might vary. And frankly, safety regulations and enforcement for things like traffic or building codes are often less stringent in low and middle income countries.
And traveler behavior itself can play a role.
Sometimes, yes. Travelers might engage in more risk-taking behaviors than they would at home, often influenced by alcohol. And critically, if a serious injury does happen, access to high-quality trauma care can be severely limited or non-existent in many parts of the world.
Motor vehicle accidents seem particularly common.
They consistently rank as a leading cause of injury deaths for travelers. Risks include poor road conditions, different driving styles, less strict traffic enforcement. It's strongly advised to avoid riding motorbikes, especially without helmets. Be wary of overcrowded buses or poorly maintained vehicles. Always use seatbelts if available. Beyond road safety, drowning prevention and basic crime avoidance strategies are also really important parts of pre-travel counseling. The U.S. State Department website is a good resource for country-specific safety advice.
What about travelers with pre-existing medical conditions? More people are traveling with chronic illnesses now.
It's much more common. And their risks obviously vary depending on the condition, the destination, the activities planned. Careful planning and a pre-travel consultation with a regular doctor to assess fitness for travel and ensure their condition is stable are essential.
Any specific risks to highlight?
Cardiovascular events, heart attacks, strokes are actually a frequent cause of in-flight medical emergencies and deaths during travel. Also, managing conditions like diabetes can be challenging with time zone changes affecting medication schedules and dietary shifts impacting blood sugar control.
How can providers best support these travelers?
Providing them with copies of their prescriptions, a clear list of their medical problems, maybe a baseline ECG if they have heart issues. That can be invaluable if they need care abroad. And critically, carefully reviewing their medication list for potential drug interactions when adding travel meds like antibiotics or malaria prophylaxis is vital. For example, some antibiotics can interact dangerously with certain antidepressants or heart rhythm drugs. Some malaria drugs can affect INR levels in patients on warfarin. These interactions are hard to manage far from home.
Let's talk about immunocompromised travelers, a diverse group facing higher risks.
Absolutely. This includes organ transplant recipients, people with HIV, cancer patients on treatment, those without a spleen, people on various immunosuppressive therapies like biologics, chemotherapy, or chronic high-dose steroids.
What are the general concerns for them?
Increased susceptibility to a wider range of infections, sometimes more severe illness. Vaccines might be less effective for them. And critically, certain live virus vaccines are contraindicated if their immune suppression is severe.
So basic precautions are even more important.
Especially important. Meticulous food and water hygiene, rigorous insect bite prevention. These standard measures are non-negotiable for this group.
When are live virus vaccines definitely off limits?
Generally contraindicated in states of severe immunocompromise. Think active leukemia or lymphoma, widespread cancer, severe transplant complications like graft versus host disease, advanced HIV/AIDS with very low CD4 counts, under 200. Also, being on high-dose steroids, like 20 milligrams or more of prednisone daily for 2 weeks or longer, certain chemotherapy agents, or powerful biologic drugs that deplete immune cells.
So timing of vaccines relative to immunosuppressive treatment is key.
Crucial. If possible, travel vaccines should be given before starting immunosuppressive therapy, ideally at least 2 weeks prior for inactivated vaccines and 4 weeks prior for live vaccines. And some therapies, especially biologics, cause prolonged immunosuppression even after they're stopped. If a required vaccine like yellow fever can't be given due to immunosuppression, a medical waiver is needed, along with careful counseling about the risks. The CDC Yellow Book has detailed guidance.
What about travelers with HIV specifically? How does their risk track with their health?
Generally, their infection risk correlates pretty well with their CD4 T cell count, which measures immune function. Those with well-controlled HIV and CD4 counts above 500 usually have risks similar to non-immunocompromised travelers.
Can they receive live vaccines?
Live MMR and varicella vaccines are generally considered safe if their CD4 count is stable above 200 for at least 6 months. Yellow fever vaccine guidance depends on the CD4 count, as we discussed, usually avoided if under 200. But the oral live typhoid vaccine and the live flu nasal spray should not be given to anyone with HIV. Safe inactivated alternatives exist for both.
Are there still countries that restrict entry for people with HIV?
Fortunately, the number has decreased dramatically, especially for short-term tourism. But restrictions can still exist, particularly for longer stays, work permits, or residency. So HIV-infected travelers should definitely check the policies of their destination country well in advance through embassies or reliable online resources.
Pregnant travelers, another group needing special consideration.
Definitely. Providers need to assess pregnancy status and the possibility of conception during travel planning. Pregnant travelers face unique risks: potentially limited access to emergency obstetric care abroad, increased risk or severity of certain infections, and exposure to infections that could harm the fetus.
Is there a best time to travel during pregnancy?
Most airlines allow travel up to 36 weeks, but the American College of Obstetricians and Gynecologists, ACOG, generally recommends the middle trimester, weeks 14 to 28, as the safest and most comfortable time. Morning sickness is usually eased, mobility isn't too impaired yet, and the risks of miscarriage or premature labor are lowest. The CDC Yellow Book details many specific precautions and contraindications for travel during pregnancy.
Are certain infections particularly dangerous during pregnancy?
Yes, pregnant women are at higher risk or can get sicker from infections like malaria, influenza, hepatitis E, and listeriosis. And infections like Zika, toxoplasmosis, and rubella can cause devastating birth defects or fetal death.
So risk mitigation is key.
Absolutely. Pregnant travelers should seriously consider delaying travel to areas with high risk of dangerous infections like malaria or ongoing Zika transmission. Malaria prevention options are limited during pregnancy. Only mifloquine and chloroquine are considered generally safe, and resistance is an issue. Few travel vaccines are considered safe. However, EPA-registered insect repellents, including DET, are considered safe and are highly recommended when used as directed.
Finally, travelers with severe allergies. This must be incredibly stressful.
It really can be, especially going to places without readily available emergency care. Avoiding food allergens is a huge challenge, dealing with restaurants, language barriers, hidden ingredients in regional cuisine, cross-contamination risks. Insect stings are another major worry. Solo travelers face particular difficulties if they have a reaction.
So preparedness is everything.
Absolutely essential. They must have a clear emergency action plan and carry adequate self-treatment supplies. That means at least 2 epinephrine auto-injectors, plus antihistamines. It's also wise to carry rescue inhalers if they have asthma, and maybe a short course of oral steroids, especially if traveling remotely.
What about documentation?
Carrying written documentation of the allergy and the self-treatment plan and medications, especially injectables, is vital for customs or if they need medical help. Proactively informing restaurants and hosts is important. Using translated allergy alert cards can be very helpful.
Right, so having the right plan, the right information, and the right gear. Which brings us to the practicalities. Health kits, navigating medication rules, and insurance.
Exactly. These practical aspects are just as vital as the medical advice for a safe trip. A well-stocked travel health kit is your personal safety net.
What's its main purpose?
To minimize the need to seek medical care for common self-treatable conditions. It lets you handle minor issues yourself without derailing your trip to find a pharmacy or clinic in an unfamiliar place.
And the contents should be personalized?
Completely. It depends on where you're going, how long you'll be gone, what you'll be doing, and your own health issues.
Yeah.
But there are some core components.
Like what?
Definitely any prescribed medications like malaria pills or antibiotics for TB self-treatment. These must be kept in their original labeled prescription bottles. That's crucial for customs and identification.
Okay. And over-the-counter stuff?
Think basics. A digital thermometer, pain fever reducers like ibuprofen, acetaminophen, an antidiarrheal, loperamide, maybe motion sickness meds, antacids, laxatives, oral rehydration salt packets, antihistamines for allergies, topical steroid cream for rashes or bites.
And basic first aid.
Yes, things like gloves, assorted bandages, medical tape, antibiotic ointment, tweezers. And a critical point: any essential medications you rely on daily should always be in your carry-on luggage, never in checked bags. Just be aware of airline rules about liquids or sharp objects like tweezers and carry-ons.
Now, traveling with those prescription medications can be tricky due to international rules.
It can be a real headache and potentially a serious problem if you're not prepared. It's highly recommended to carry copies of your prescriptions, or even better, a signed letter from your doctor listing your medications and why you need them.
Why is this so important? Are rules really that different?
Hugely different sometimes. Many countries, especially in Asia, the Middle East, and Africa, have much stricter regulations than the U.S. on certain drugs. This often includes controlled substances, opioid painkillers, anxiety meds, sedatives, ADHD medications. But surprisingly, it can even apply to some common over-the-counter drugs like pseudoephedrine, a decongestant, or diphenhydramine, and antihistamine.
Wow. So, how do you find out the rules for your destination?
Requirements vary wildly. Some countries just want the prescription copy. Others might require you to get advance approval from their health ministry. Enforcement and penalties also differ greatly. The only safe way is for travelers carrying potentially restricted medications to contact the embassy or consulate of their destination country well before they travel to check the specific policies. And only carry enough medication for the duration of your trip. There are some online resources that try to compile this info, but the embassy is the definitive source.
What about buying medications overseas if you run out or need something?
This is another area for serious caution. While you might find familiar medications available over the counter abroad, the quality can be highly variable.
You mean counterfeit drugs?
Exactly. Counterfeit medications are a massive global problem, especially for things like antimalarials, antibiotics, and lifestyle drugs.
Yeah.
They might contain the wrong ingredient, the wrong dose, no active ingredient at all, or even harmful substances. Because of this risk, travelers are strongly advised to avoid buying critical medications overseas whenever possible. Bring an adequate supply of anything essential, especially malaria pills or chronic disease meds, from a trusted source at home before you leave.
Okay, beyond medications, what about actually accessing healthcare overseas if something serious happens? And insurance?
This requires planning before you go. Travelers should think about where they would go for urgent or emergency care, especially if they have chronic conditions, are pregnant, or are doing high-risk activities. The crucial thing to understand is
Yeah.
your regular health insurance from home almost certainly will not be accepted for payment in most other countries. And it probably won't help you find reputable local doctors or hospitals.
So, reviewing your policy is step one.
Absolutely imperative. Check the fine print for coverage limits and exclusions. Does it cover pre-existing conditions, high-risk activities like skiing or scuba diving, mental health care, emergency room visits, hospitalization, psychiatric care, pregnancy complications? Also, check if it includes 24-hour assistance, ideally with medical professionals who can help coordinate care and provide guidance in an emergency.
So, for many people, supplemental travel insurance is probably a good idea.
A very prudent investment for most international trips. There are different types.
Wait, what?
Basic travel insurance often covers things like trip cancellation or lost luggage. Travel health insurance specifically covers medical costs incurred overseas, usually including that 24-hour assistance. And medical evacuation, medevac insurance, covers the potentially enormous cost of transporting you to a higher level of care, or even back home if the local facilities are inadequate for your medical needs. Medevac can be a standalone policy or part of a comprehensive travel health plan. Researching options online is worthwhile.
Let's quickly touch on some of those special travel populations again and how advice might be tailored. VFRs visiting friends and relatives.
Right. They often have higher risks because they might stay longer, go to non-tourist areas, live in local homes, eat local food. Their exposure is different. And that mistaken assumption about retained immunity to things like malaria is common. Barriers can include cost, language, maybe less trust in formal healthcare. Strategies for providers include routinely asking about travel plans during regular checkups and helping prioritize the most critical vaccines and preventive meds if budget is tight.
Budget travelers.
Similar financial barriers to pre-travel care. They might use lower quality accommodation, transport, food, all increasing risk. Again, prioritization is key, focusing limited resources on the highest risks. Plus, education about specific high-risk behaviors, like avoiding cheap but dangerous motorbike taxis.
Last-minute travelers. Not much time for prep.
It's a common scenario. Focus on what can be done quickly. Single-dose vaccines if applicable. Accelerated schedules for others if there's even a week or two. Malaria pills can often be started just a day or two before entering a risk area. For people who travel unpredictably, like flight crews, maybe maintaining broad baseline immunization and having a standing prescription for malaria prophylaxis makes sense.
Long-term travelers. Different challenges again.
Increased cumulative risk of both infection and injury due to the longer exposure time. Higher likelihood of adopting local standards for food, water, transport. Need a plan for extended malaria prevention. Strategies include greater emphasis on vaccines for diseases with cumulative risk, like hepatitis B, rabies, typhoid, maybe Japanese encephalitis, depending on the region, and figuring out logistics for long-term malaria prophylaxis.
Healthcare workers on medical missions, putting themselves in harm's way.
Often, yes. Risks include exposure to infections from patients, sometimes with inadequate infection control available, high prevalence of untreated diseases like TB, HIV, Hep B C in some settings, access to post-exposure prophylaxis if they have a needle stick might be limited or non-existent, exposure to emerging infections during outbreaks. Strategies: ensure all recommended healthcare worker immunizations are up to date. Assess the availability of PPE and things like HIV PP kits, maybe advise bringing their own. And caution against working with inexperienced organizations that might not have adequate safety protocols.
And medical tourists, traveling specifically for procedures.
A growing trend, but with unique risks. Hospital-acquired infections, complications from surgery performed perhaps to different standards. Concerns about facility accreditation, infection control practices, drug quality, blood screening. Also, increased risk of blood clots after surgery, especially combined with long flights home. Providers should counsel on these potential risks, try to direct patients towards internationally accredited facilities if possible, and stress the importance of getting complete medical records for follow-up care back home.
Okay, so the trip is over, the traveler is back home. What if they get sick after returning?
Any acute fever in a returning traveler needs to be taken very seriously and evaluated promptly by a doctor. It could be something life-threatening, like malaria, typhoid fever, leptospirosis, or acute schistosomiasis. Early diagnosis and treatment are critical.
Even if the trip was weeks or months ago.
Yes. While many common travel infections show up within a couple of weeks, some important ones like malaria, typhoid, lepto, schisto can have much longer incubation periods. Symptoms might not appear for weeks or even months after exposure.
So the key message is,
always tell your healthcare provider about your travel history, no matter how long ago the trip was, if you become ill. For malaria, doctors need to consider exposure up to a year prior. If a provider isn't familiar with infections from the region the patient visited, they should consult with an infectious disease or travel medicine specialist or the local public health department. Getting the right diagnosis quickly is paramount.
And finally, the constant challenge of outbreaks and emerging infectious diseases.
It's a perpetually moving target. Emerging or re-emerging infections constantly create challenges for travel. Think Ebola, Zika, new flu strains, novel coronaviruses. Information during the early stages of an outbreak is often limited or changes rapidly.
How do providers help travelers navigate that uncertainty?
By staying vigilant, reviewing travel health notices from CDC and WHO, checking surveillance reports, reading the clinical literature, we help travelers weigh the risks and make informed decisions. Sometimes, if the risk is deemed too high or too uncertain, the best advice might honestly be to postpone or cancel travel to that specific area.
And outbreaks of known diseases in unexpected places can cause major disruption too.
Absolutely. The yellow fever outbreak in southeastern Brazil in 2017-18 is a perfect example. It hit major tourist destinations like Rio and São Paulo, areas not previously considered high risk, requiring vaccination for many travelers who wouldn't have needed it before. And to make matters worse, it happened during a period of yellow fever vaccine shortage in North America, creating huge logistical challenges.
So we've really covered the spectrum of travel health preparedness, management, and follow-up. But you mentioned a bigger force at play, climate change. How does that connect to all this?
It connects profoundly. It's the overarching context in which all these travel health issues now operate. Climate change isn't just an environmental issue. It's a fundamental driver of changes in infectious disease patterns globally.
It sounds like we've entered a completely new era for health because of it.
In many ways, we have. The huge amounts of greenhouse gases, mainly carbon dioxide, released since the Industrial Revolution, have created a climate that's fundamentally different from the one humanity evolved and thrived in. This human-driven change has already altered the epidemiology, the who, what, where, when, and why of infectious diseases around the world.
And the future looks even more challenging.
Continued accumulation of these gases will further alter the climate, which will, in turn, continue to influence the incidence, severity, and geographic range of infections. Sometimes it might favor the emergence or spread of diseases. Other times, paradoxically, it might make areas currently suitable for a disease unsuitable, perhaps due to extreme heat or drought. It's complex.
So when we say climate change, what are we technically talking about beyond just global warming?
It refers to long-term shifts measured over decades or longer in average weather patterns. This includes changes in temperature, but also precipitation, wind patterns, humidity, frequency of extreme weather events, the whole system.
How does this compare to natural climate cycles in Earth's past?
Earth has naturally cycled between ice ages, glacial periods, and warmer periods, interglacial, over millions of years, with global temperatures fluctuating maybe 4 to 7 degrees Celsius between extremes. The last ice age ended around 12,000 years ago.
But the current period, the Holocene, has been different.
Remarkably stable. For the last 10,000 years or so, global average temperature stayed within a relatively narrow range, maybe 2 to 3 degrees Celsius. That stability was incredibly important. It allowed agriculture to develop, populations to grow, civilizations to flourish.
So what makes today's climate change different from those past cycles?
Two key things. Its primary cause, human activities, mainly burning fossil fuels, and its speed. The current rate of warming is faster than any known warming period in at least the last 50 million years. The Earth's climate system is changing incredibly rapidly.
And projections suggest more warming is coming.
Yes, unless we drastically reduce greenhouse gas emissions very soon. Moderate projections suggest an additional warming of somewhere between 1.4 and 3.1 degrees Celsius by the year 2100, compared to the late 20th century baseline. Climate science is getting clearer and clearer about the trajectory we're on and its potential consequences.
Let's break down these greenhouse gases, GHGs. You called them Earth's thermal blanket. How do they work?
It's a good analogy. GHGs are specific gases in the atmosphere that have the ability to absorb infrared radiation, essentially, heat energy radiated from the Earth's surface. Without this natural greenhouse effect, Earth would be about 33 degrees Celsius colder, basically a frozen ball.
Which GHG is the main driver of the recent warming?
Carbon dioxide, CO2, has had the biggest impact since the Industrial Revolution started. It comes mainly from burning fossil fuels, coal, oil, natural gas, and also from deforestation, which reduces the planet's ability to absorb CO2. Interestingly, a scientist named Svante Arrhenius predicted back in the 1890s that increasing CO2 would warm the planet. Quite prescient.
What about water vapor? I hear that's a powerful GHG too.
It is the most abundant and a very potent one. However, it's not considered the primary driver of the current warming trend itself. Why? Because its concentration in the atmosphere is largely controlled by temperature. Warmer air holds more water vapor. It acts more like a powerful feedback loop. As the planet warms due to CO2 and other GHGs, more water evaporates, increasing water vapor, which then traps more heat, amplifying the initial warming.
Can you walk us through the physics of the greenhouse effect simply? How does CO2 actually trap heat?
Okay, think of it like this. Sunlight, which is mostly visible light, shortwave radiation, comes into the atmosphere. Some is reflected back to space by clouds and surfaces like ice. Most gets absorbed by the Earth's surface, warming it up.
Right.
Now, the warmed Earth radiates that energy back outwards, but crucially, it radiates it as infrared radiation, longer wavelengths, basically heat. Greenhouse gases like CO2 and methane are special because their molecular structure allows them to absorb energy at these specific infrared wavelengths. Oxygen and nitrogen, the main gases in the air, don't really do this.
So they block the heat from escaping.
Exactly. They absorb that outgoing infrared energy and then re-radiate it, some back down towards the surface, effectively trapping heat in the lower atmosphere. It's like adding layers to that thermal blanket. More GHGs mean a thicker blanket, trapping more heat, leading to warming. The change in wavelength from incoming sunlight to outgoing heat is key to why GHGs have this effect.
So temperature shifts are the most obvious link to disease. Global warming isn't just about average temperatures rising, is it?
No, the average warming about 0.85 degrees Celsius since 1880 hides really important details. Some regions are warming much faster, like the Arctic, which is warming at least twice the global average rate. Winters are generally warming faster than summers, and nighttime low temperatures are rising faster than daytime highs.
And these nuances matter for infectious diseases.
They matter hugely, especially for diseases spread by vectors like mosquitoes or ticks. These creatures are cold-blooded, so their development rates, survival, activity periods, and geographic ranges are highly sensitive to temperature. Warmer temperatures can allow them to expand into new areas, survive winters where they couldn't before, reproduce faster, or bite more frequently, all potentially increasing disease transmission.
What about extreme heat events, heat waves?
They're already more common and projected to become even more frequent and intense. Beyond the direct health impacts on people, heat stroke exacerbating chronic illnesses, heat waves can devastate agriculture. Think about the 2010 Russian heat wave massive wildfires. Air pollution estimated to cause tens of thousands of deaths, and it wiped out a huge portion of their wheat crop.
How does crop failure link to infectious disease?
Because malnutrition and food insecurity severely weaken people's immune systems, making them much more vulnerable to infections of all kinds. Undernutrition is a major underlying factor in the global burden of infectious diseases. So, climate impacts on food production have direct knock-on effects on health and disease susceptibility.
Beyond temperature, climate change also messes with the water cycle, precipitation changes, right? More intense rain, deeper droughts.
Exactly. A warmer atmosphere holds more energy and more water vapor, which intensifies the whole water cycle. We're seeing measurable increases in the frequency and intensity of the heaviest rainfall events in many parts of the world. North America, Europe, likely Southeast Asia. But other regions are seeing more prolonged and severe droughts, like the southwestern U.S. or parts of Australia.
How does more water vapor lead to both floods and droughts?
Well, warmer air holds more moisture, about 6–7% more per degree Celsius of warming. So when it does rain, there's more water available to fall, leading to heavier downpours and increased flood risk. This can overwhelm sanitation systems, contaminate drinking water sources, and create breeding grounds for mosquitoes, increasing risks of waterborne and vector-borne diseases. Conversely, changes in atmospheric circulation patterns driven by warming can shift rainfall patterns, leading to prolonged dry spells and drought in other areas. Drought concentrates people and animals around limited water sources, potentially increasing disease transmission and impacts hygiene and agriculture. These fundamental shifts directly alter the environmental conditions that favor or suppress different pathogens and their vectors, linking climate change directly back to travel health and global health security.
Wow, okay. We have covered a huge amount of ground today, from the really personal decisions you make before hopping on a plane internationally, right down to these massive global forces of climate change.
It's a lot to take in. We've seen how getting into the details, immunisations, malaria prevention, even just packing the right things in your health kit can genuinely make a difference for a traveler's health and safety.
And we really dove into the specific needs of different travelers, immunocompromised people, pregnant individuals, those VFR travelers visiting family.
Yeah.
The advice isn't one size fits all.
And what's really striking, I think, is how interconnected it all is. Our ability to travel anywhere, anytime, while amazing, creates these superhighways for infections.
Right. And then layered on top of that, as we just explored, climate change is fundamentally rewriting the rules for where and when these pathogens thrive, changing temperatures, altering rainfall, impacting everything from mosquito habitats to our food supply.
Which in turn affects our vulnerability to those infections. It's all linked.
So, a final thought for everyone listening. As you plan your next trip, maybe even just thinking about health in your own community, consider this ripple effect. How might the choices you make in preparing for travel and understanding these larger environmental shifts, how might that not only protect your own health, but also contribute, even in a small way, to a more informed, maybe more resilient world? What stands out to you as the most impactful change or adaptation we need to make in this new era of global health? Something to definitely mull over.